A very good morning to all of you. This presentation is about our functional abilities which preserve our health and prevent and manage many of our diseases, particularly in the old age. So let me just share the screen to show you my presentation. So I'll just put it on the slideshow. So here we go. So this is all about the functional and social approach to the management and care of diabetes in elderly patients. Let it be known that World Health Organization in their integrated care for older people called ICOP program recognizes six functions which are liable to progressively decline with aging, namely cognition, mobility, vitality, the key source of which is nutrition, vision, hearing, and psychological capacity, which prevents for our anxiety, depression, etc. And all these functions are collectively termed as intrinsic capacity of an individual. The good news is that much of this decline is preventable. Declining intrinsic capacity is a forerunner of many geriatric syndromes and often complicates the life of elderly people and many disorders of old age, including diabetes. This is an area of interest to diabetologists because diabetes has a bi-directional relationship with intrinsic capacity. That is, diabetes on one hand promotes and accelerates the decline of these functions, while these declining functions increase the risk of diabetes and interfere the control of diabetes in elderly due to a variety of reasons listed below. They cannot self-manage diabetes properly, they cannot do exercise well, they neglect their food, they are often non-compliant to medical advice, and there are social factors which also prevent the same, like isolation and loneliness. Diabetes also contributes independently to a number of geriatric syndromes like dementia, frailty, falls, incontinence, polypharmacy, visual and hearing impairment, and depression, severely thereby impacting quality of life with poor diabetic control. This functional approach to the management of diabetes is an emerging concept, I think, because declining intrinsic capacity in old age brings the not only the risk of diabetes, as I told you, but also interferes with the diabetic management. Thus, a better diabetic control among the elderly by improving their declining function remains a distinct possibility. There are lots of reports in literature. People have evaluated their elderly and frail diabetics for intrinsic capacity. They have also shown that intrinsic capacity goes down in elderly diabetics and it is proportional to increasing glycemia. And one of the reports says that increasing the muscle strength to improve functional ability may be a possible intervention to reduce the risk of type 2 diabetes mellitus in older population. Now, I think it is important since physicians' choice of diabetes management and its glycemic goals for elderly patients is quite dependent on the degree of intrinsic capacity functional decline and its consequences as geriatric syndromes. It becomes imperative to stratify such patients according to their intrinsic capacity. This requires screening and assessment of patients for functional decline and provide appropriate management to them. This is an ICOP tool provided by World Health Organization, which helps us in quickly screening and detecting the various functional disabilities or impairments listed on the left side. There is a video which shows that this tool can be completed in just 7 minutes, and I'm not going to go into the details about each of these detection programs. But there are some questions that have to be asked and some very simple tests have to be done. On the right side, this is the something which can be done by healthcare professionals only. through certain validated instruments if an in-depth assessment is required for the various impairments of our functional abilities. I might add here that the quick screening tool can be just done by any community health worker or a trained family caregiver. Now, having detected any intrinsic decline, if any, we have some quick primary care actions, although there is something more which I will be describing later. For cognition, we need primarily cognitive stimulation. For mobility, multimodal exercise. For nutrition, diet counseling and dietary advice. For vision and ophthalmology, vision and hearing, we need to refer whenever necessary to eye specialists and ENT specialists. And for depression, we need psychological support from the specialist whenever needed. Now, this is a little bit of deep diving about preventing and managing of impaired cognition. Firstly, I have already mentioned cognitive stimulation. There are four methods to perform this. First is self-brain challenging. By that I mean we should encourage the elderly people, and the elderly people should by themselves try to accomplish tasks with some mental effort. For example, they may like to learn a new musical instrument. They may like to learn a new language. They may do new reading, or they may play chess, or simply play the playing card and have fun with puzzles, etc. Recollection exercises means you are reminiscing them. You are trying to stimulate their memory apparatus. This it can be done by reminding them on a particular day what is the day today, the time, the date, what is the weather, what are the other kind of things that they would like to remember. For example, childhood memories, looking at family albums and naming the household items that they might have forgotten the names. So these are the recollection exercises. And then I think we can also specifically stimulate certain senses. For example, the sense of sight can be kept accelerated by daily habit of reading a newspaper, for example, or watching the television programs. The hearing can be stimulated by listening to religious discourses, for example, or having talking on telephone, or having other kinds of program, like for example on radio. These are all stimulation of hearing senses. Social interaction is very important. I think the elderly people have to be encouraged to involve themselves in group community work, in group walking, and in group reminiscences, and connecting with the younger generations. Multimodal exercises named here are simply good for brain health. For in addition, there are certain conditions which need to be addressed if necessary. Malnutrition and polypharmacy both are the risk factors of impaired cognition. Other intrinsic capacity functions that I named, like vision, hearing, nutrition, I have already told you, or depression, for example, or even mobility, they have to be addressed because they are also somewhat risk factors for impaired cognition. And there are other cardiovascular risk factors like obesity, hypertension, and cholesterol, and so on. They all have to be addressed. Now, coming to the prevention and management of impaired mobility, again, exercise and nutrition, particularly the strengthening exercises, which strengthen our muscles and indirectly they help in the control of diabetes. Of course, other exercises, including yoga, are also important. And if necessary, the protein intake might have to be increased because they are building blocks for our muscles. Managing conditions at present like arthritis, sarcopenia is loss of muscle again, polypharmacy because many drugs, they can dull our consciousness, they can bring down our alertness, and maybe they make a person vulnerable to mobility. And if there is any pain, that has to be addressed again. Managing environment is very important. House has to be adapted properly. It has to be age-friendly house. There should be no clutter. There should be clear walking pathways. There should be no slippery bathrooms. There should be no loosely fitting carpets, etc. And assisted devices, whenever necessary, are to be provided. And safe walking spaces in the green spaces outside also important. And if necessary, they may have to be referred for rehabilitation. The other declines include nutrition, vision, hearing, and depression. For nutrition, diet counseling, exercises are also important for exploiting the use of nutrition and vitality. Monitoring of weight is important. Intake of vitamin D, proteins, and keeping fully hydrated is as well important. Family and social dining gives a psychological boost for dietary intake and nutrition intervention. Treat sarcopenia and frailty when present. For vision and hearing decline, again, housing adaptation is important. Again, I would say it has to be age-friendly house, good light, good vision. There should be no darkness in any part of the house, especially for visually impaired people. There should be doorbell sound and phone sounds reachable to hearing impaired people. They should be available at different parts of our house. Family and social interaction important for both visually and hearing impaired because they shy away from interaction because of their impairment. Avoid noise exposure for those who are hearing impaired and for those who are visually impaired. If they harbor hypertension and diabetes, they need to be treated. And whenever necessary, a specialist referral will be required. For depression, life review therapy means you have to remind them and counsel them with past happiness and events which were welcoming to them. For example, when were they get married? What are the family albums? When did they become grandparents? All those things will be helpful to them. Exercises are again important because exercise, even physical exercise, not only elevates the cognition, it elevates the mood also. Mindfulness practices like yoga or breathing exercises are important. And of course, again, it is the social support and rich connectedness which has to be encouraged for people who to prevent depression and referral to psychologists whenever needed. This is the last presentation or slide, social prescription. Now, I have already alluded to partly about the social intervention while I was dealing with intrinsic capacity. Diabetic distress, loneliness, anxiety, and depression are known to have negative impact on general feeling of well-being. It has also been shown that engaging elderly with non-clinical social activities, either at voluntary or community sector, are known to improve diabetes control with a positive impact on HbA1c. It is also recommended that social prescription should be explored as an integral part of diabetes care. It has also been shown that walking, grouping, etc., socially prescribed whenever is done, it shows to influence diabetes outcome. There are plenty of examples of social intervention like social, religious, family, voluntary, and internet-based activities, like intergenerational activities, community knitting, community cooking, environmental cleaning, community gardening, tutoring, spiritual exercises, etc., etc. Places like resident welfare associations, recreation clubs and centers, non-government organizational and community sites are available in plenty in our country, and I think they should be made use of. This social prescription term originated from NHS in UK, and once it is formalized, certain stakeholders have to be included in the whole thing. Thank you very much, and I hope you enjoyed this video, and I come to the end of this presentation. Thank you once again.